Assalamualaikum warahmatullahi ta'ala wabarakatuh and good day everyone. I am Dr. Khasnizal Abdul Karim. I'm a general surgeon from Hospital Tawau, Sabah. I would like to congratulate to the organizing committee of 8th Virtual Plasma Biennial Congress 2021, and I would like to thank you them as well for inviting me to talk in this congress. My topic for today is enteral feeding. Why and how to monitor. This is the outline of my presentation, which include introduction, why we need to monitor AEN, and how to monitor. Feeding is our basic needs, which we provide adequate nutrition to meet our demands. Healthcare providers to our patients, it is a responsibility to us to provide adequate and safe delivery of nutrition by any means, by parenterally, enterally, or orally. Enteral nutrition is more superior to parenteral nutrition when GI tract is functioning, which carry less complication and adverse events. Hence, monitoring is important to identify the complication and adverse event or effects of enteral nutrition early. Why we need to monitor in enteral nutrition? As I mentioned just now, by monitoring, we can minimize the side effect and adverse effects. So if we reduce the incidence of complications like aspirations, feeding intolerance, and Barrett-Buckle syndromes. We will reduce the electrolyte and metabolic abnormalities and ensure adequate nutrition to the patients. How frequent we need to monitor? It depends on the underlying clinical condition. Some patients may need regular, close monitoring of enteral nutrition, like patient who has underlying diabetes mellitus, bleeds, congestive cardiac failure, chronic renal failure. This patient require very close monitoring. It depends on the duration and tolerance of enteral nutrition. Patients who are on the short terms of the enteral nutrition and high risk to develop intolerance, this patient require very close monitoring in clinical settings, like for example in district hospital, which has a limited biochemistry panels, so certain biochemical monitoring can be done. Availability of appropriate expertise, like clinicians who are expert in managing enteral nutrition and parenteral nutrition, and as well as dietitians. Who should monitor this? Okay. So this monitoring should be done by trained healthcare workers, like our trained nurses in the ward, dietitians, and trained clinicians. For those patients who are long-term EN or patients who are home-based EN, the carers of the patient can be trained and educated to do the monitoring. So how to monitor? So I have outlined few ways, few parameters, the frequency and the rationales of each of the parameters. First of all is our food chart, or I would like to call it food intake diary. So this should be done daily by doctors and nurses in the ward. It is useful for us to adjust the adequacy of nutrition according to patients' requirements. At the same time, it is very helpful for us to plan the transition between the nutrition support, from enteral nutrition to oral nutrition. The next thing will be a fluid balance chart, which includes the IV medications, IV fluids, and oral fluids. So in acute setting, it should be done daily. It is very useful for us to assess the hydration status, especially in patients who are who has a congestive cardiac failure and chronic renal failure. At the same time, it can be used to compare the fluids or the fluids given with a fluid or fluids prescribed by the clinicians. Okay. They are also useful in assessing the fluid volume prescribed and fluids given to the patient. The next parameter will be a weight or BMI. But for those patients who have difficulty to obtain the weight, so we can use their mid-arm circumference and tricep skin fold thickness to estimate the weight. So it should be done twice weekly. Okay, for those patients who has a short-term nutrition, but monthly for those patients who are on a long-term home-based EM. So these two function, the reason why we need this because we need to monitor changes on hydrations and body compositions over a period of time. At the same time, we want to see that the patient has gaining some weight over a period of time. If patient in the ward, we should examine the abdomen daily. Look for any evidence of renal distensions. Okay? Look for any evidence of diarrhea, because we need to know by having renal distensions and diarrhea, it reflects there is a intolerance towards the enteral mutations. For patients who are diabetic, capillary blood sugar should be done 4 hourly. Okay. For those non-diabetic patients, it is adequate if you want to monitor randomly once a day. This is to detect any hypo or hypoglycemia episodes and to ensure the timing of the feeding and medication optimal for blood glucose control. Some medication can be administered through the tube, rice tube, estrostomy tube, and PEG tubes. Okay, so it should be done daily, just to ensure the potential side effects and drug-nutrient interaction are identified and prevented, and to ensure the drugs are appropriate presentation and suitable for tube administration. For example, sugar-coated medications cannot be crushed and administered through the tube feeding. You should monitor daily for episodes of nausea and vomiting. Nausea and vomiting reflects the feeding intolerance. For those patients who has gastric dysfunction and gastric emptying problem, patient may have high residual gastric volumes. So this, most of the time in acute setting, we need to monitor this 4 hourly. It is also important for us to plan about the appropriateness of increasing the feeding rates. For example, those patients who has a high gastric residual volumes compared to the feeding rate, so it is not appropriate for us to increase the feeding. Next, I'll talk about the tube. As you know, we have various types of tubes in delivering the enteral mutations. One of it is the nasogastric tube, estrostomy tube, and PEG tube. So we have to make sure that the positions of the tubes are appropriate to prevent complication. So any tube must be checked before every feeding, before every fluids and medication administration, as well as the estrostomy and PEG tube. It should be checked by looking at the external bumper marking. Why we need this? Why we need to monitor this? Because we need to prevent nasogastric malposition, which can lead to aspiration. At the same time, we need to ensure that the feeding tube not migrated away from the stomach or into the stomach. I'll show you the picture afterwards. Feeding tube insertion site must be checked daily. This is to look for any evidence of infections, soreness, and leakage. We should check for any evidence of nasal erosions and nasal septum necrosis to ensure that the tube is appropriately secured, especially the nasogastric tube. The tube integrity must be assessed daily to ensure the safety leakage. So these are the examples of tubes that commonly used. So this is the PET tube. Right, so this is the external bumper, and this is the nasogastric tube. We need to make sure that the external bumper is fixed to the anterior neural wall. So every day we have to flip the external bumper to look for any evidence of skin excoriation, skin granuloma. Sometimes you may find there is a necrosis, skin necrosis as well. And the worst thing is it can cause buried bumper syndrome. Okay, so for the nasogastric tube, we have to make sure that the nasal septum is not eroded, or patient may have what we call a nasal septum necrosis. So this one of the this essay showing is the nasogastric tube being misplaced into the right lungs. What happens if you feed patient through these malpositioned tubes? So it will cause aspiration. We should identify this to prevent fatal complications. So these are the things that we need to monitor every day. So we look for any evidence of skin excoriation. As mentioned just now, we need to flip the external bumper to look for any evidence of excoriation like this, and the skin granuloma, or sometimes you can see there's a leaking gastric content from the incision side. So this is one of the best examples of tube care. You can see the tube is blocked by the feeding, which we fail to flush the catheter and the tubes every feeding. So next will be a estrostomy examination. It should be done daily. So the idea is to prevent complications like this now, excoriations, granuloma, and the most severe form is a buried bumper syndrome. The estrostomy progression, so we should done weekly to prevent tube displacement. Oral health should be examined daily. This to optimize the oral hygiene and to reduce risk of aspiration. We need to monitor, or we need to assess patient's general conditions daily so that the feeding is well tolerated by the patient, and to ensure that the feeding and the feeding routes remain appropriate. If patients clinically improve with the feeding regimes and the feeding routes, and probably patient can start to feed through oral routes. So I think there is a time for us to consider our feeding regime and feeding routes. Most of the time, the aims and objective of the feeding and route being planned prior to starting the implementation. So these aims and objectives should be reviewed after certain time, after certain periods of time, because you want to know whether the aim and objective will be achieved. To do, and also is to ensure that the feeding regime still remains appropriate for the patient. So this is the examples of complication caused by the PET tube. As you can see here, there is a buried bumper syndrome. This is considered as a mild complication of buried bumper syndrome. The next picture showing there is a severe form of buried bumper syndrome, in which it causes skin necrosis, okay? It causes probably necrosis fasciitis, and this can cause sometimes it can be very fatal to patient as well. Alright, so now we go to the biochemistry monitoring. Okay. There are few electrolytes and trace elements and vitamins that we need to monitor. Okay, for example, we need to monitor sodium, urea, and creatinine daily until the level become very stable. The idea is to assess the fluid status of the patient, to detect electrolyte and metabolic abnormalities early, and to correct it as soon as possible, and to assess the renal function. Potassium, phosphate, magnesium, and corrected calcium. These are the electrolyte which is important for us to identify or detect any risk of refeeding syndrome. So it should be done daily during the initial stage of nutrition, okay, to identify the risk of refeeding syndrome. Then we can do it 3 times a week until it becomes stable. Glucose, yes, it is important for patients who are diabetic to ensure that patient has a optimal glycemic control. Liver function test to detect overfeeding. However, liver function test is not as crucial as in a parenteral nutrition. So it can be done weekly until it's stable and when it is necessary. Albumin, it can be done weekly until stable. However, the low serum albumin does not reflect the protein status. Most of the time, it reflects the disease process actually. Full blood count. So it is nice to do it twice weekly to monitor any signs or evidence of infections and anemia. As we know, patients who are on long-term enteral nutrition, they tend to have anemia. Sometimes it can be because of iron deficiency anemia, sometimes it can be because of the vitamin B12 deficiency anemia as well. The other biochemical elements that we need to monitor is zinc, copper, and selenium. This is what we call trace elements. So usually we monitor it when clinically indicated. The deficiency of these trace elements commonly caused by the increased loss or reduced intake. But sometimes it can be caused by the altered it can reduce or it can be affected by the disease process, infection, and trauma. Don't forget about the vitamins, especially the folate and vitamin B12, which is important for our RBC's production. Okay, so deficiency common in certain disease states. For example, patient who has a short bowel syndrome and so on. Vitamin D, this is very useful in those patients who has a long or who is on a long-term nutrition support. Okay. So in summary, so we need to monitor enteral nutrition. Why? Because to ensure that nutrition delivered adequately to meet the demand of the patients and to ensure the delivery of the nutrition is safe and to identify any potential complication and adverse events early. The monitoring can be done by trained healthcare personnel like nurses, doctors, or for those patients who are on long-term home-based EN, we should train and educate the carers. Watch out for feeding tube positions and insertions and potential local complications like nasal septal necrosis and erosion, skin exfoliation, and Barrett Marker syndromes. We should monitor any electrolyte imbalance and metabolic abnormalities regularly. With that, I thank you.